You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for February 22nd, 2019. This week, Factor Xa reversal, post-traumatic stress disorder, the cardiovascular risks of changing genders, the primary care physician shortage, and interventional cardiology. First up, Andexa alpha is a modified, recombinant, inactive form of the human Factor Xa developed for reversal of Factor Xa inhibitors. This drug binds and sequesters Factor Xa inhibitor molecules. The Andexa 4 study, published in the New England Journal of Medicine, evaluated 354 patients who had acute major bleeding and were given the reversal agent. This was a single-arm, no-control study. It had a co-primary endpoint of percent change in anti-Factor Xa activity and a percent change in patients with excellent or good hemostasis at 12 hours. There was a primary safety endpoint of death, thrombotic events, and the development of antibodies to the drug. The mean age of these patients was 77, and most had heart disease. About two-thirds of the bleeding episodes were intracranial hemorrhages, and a little less than one-third were GI, and then a smattering of other sorts of bleeds. And the results were that the drug reduced Factor Xa efficacy by greater than 90%, whether it was apixaban or rivaroxaban that it was reversing. And of the 249 patients who could be evaluated, 82% had good or excellent hemostasis. However, interestingly, the reduction in anti-Xa activity was not predictive of hemostasis overall, but was modestly predictive of hemostasis in patients with intracranial hemorrhage. Now, in terms of safety, 30 patients, or 10%, had a thrombotic event in the 30-day period, and death occurred in 14%. So some brief background. In volunteers that received either apixaban or rivaroxaban, Andexa alpha rapidly reduced both the unbound fraction of the plasma level of Factor Xa inhibitors and anti-Factor Xa activity. We also know that this drug does reverse Xa activity in bleeding in animal models. Now, the Xa inhibitors with this drug are not cleared. This differs from the mechanism of the dabigatran reversal, which binds and eliminates the drug. So in patients who have poor clearance, renal or hepatic dysfunction, once the drug infusion is stopped, the anticoagulation is still there. So the big discussion online about this drug is whether it improves outcomes. And we don't know that because Andexa 4 measured only surrogate outcomes, and there was no control group in the study. The outcomes in Andexa 4, the so-called hemostatic efficacy, or even death or thrombosis, are meaningless without a control. Now, I agree with the skeptics that scientifically it's hard to know whether this expensive drug improves outcomes. I know you might wonder how I could say that because A, these patients are bleeding, and B, the anticoagulation obviously makes bleeding worse, and the drug reverses the anticoagulation. Well, the problem is that many patients with bleeding can be supported until the anticoagulation is cleared. Many patients stop bleeding spontaneously, even on anticoagulants. And the drug has definite thrombotic effects, so they could cause harm. And finally, we have PCC agents that might work just as well. And this is surely why we need a definitive RCT, which the authors say in the New England paper will be done. Now, I hope it is a 3-arm trial with a PCC arm, control, and the Andexa alpha. But I also think some of the online criticisms of the authors and the New England Journal of Medicine editors and the FDA are way too polemical, and they're unrealistic. I love evidence as much as anybody, but I am also a doctor in the real world who uses drugs and devices that are developed by a profit-driven industry. The treatment of patients on oral Factor Xa inhibitors who have serious bleeding represents an unmet clinical need. Yes, we have to remember that more than 50,000 patients were studied in the RCTs of the DOACs versus warfarin, and that was when there was no reversal agent and there was no signal of harm. In fact, DOACs performs better. And it is true that many of these patients who are bleeding on the Xa inhibitors can be supported, but some cannot. What we're talking about here is not the middle of the curve, the average patient, but the tails, special circumstances. Okay, let's say your dad or mom who gets in a car wreck right after their morning dose of apixaban. At the beginning of the Andexa trial, no one was using PCCs, and having a control arm would have been akin to not giving vitamin K to patients bleeding out who are on warfarin. In other words, unethical. There are no perfect ways of drug approval, but I think the rapid approval of highly selected drugs like this one represents a reasonable compromise as long as there is a mandate to do a follow-up, more definitive randomized controlled trial. Now, I know my friend Vinay Prasad will say that too many cancer drugs are approved this way, and then once the drug gets established, then people are unwilling to randomize, and I get that. But in the case of the reversal agents, I think we could give regulators some wiggle room to get these things on the market and then do a definitive RCT. Second topic today is about post-traumatic stress disorder. More people, especially veterans, gain the diagnosis of PTSD. And numerous observational studies have found that PTSD associates with a higher risk of major adverse cardiac events, or MACE, even after adjustments for other conditions. And this makes sense because chronic stress could promote inflammation and high adrenaline rates and altered cortisol regulation. So researchers from the St. Louis University wanted to know more about this relationship and thought that common risk factors, smoking, hypertension, etc., might explain the association rather than just a PTSD. They used medical record data from VA clinics, and the control samples were randomly sampled from these same medical centers. The observation period continued until September of 2015. This was a mostly male sample of 50-ish-year-old men followed for 3 years, and the researchers found that the age-adjusted association between PTSD and cardiovascular events was significant. The hazard ratio was 1.41. However, after adjustment for metabolic conditions, the association was then attenuated but remained significant. Hazard ratio decreased to 1.23. However, again, after additional adjustments for smoking and sleep disorders and substance use disorders, anxiety, etc., the PTSD was no longer associated with incident cardiovascular disease. Hazard ratio now is 0.96. So, PTSD, they concluded, is not an independent risk factor for cardiovascular disease. This study gets into some hefty statistics, and it's a non-randomized comparison, but I mention it because A, risk factors often overlap, and rather than say, hey, you have PTSD, so you are at risk for heart disease, the better solution may be to look for and treat the known risk factors for heart disease in these patients. And secondly, I also think it's worth mentioning the importance of statistical adjustments. If you just did age adjustment or metabolic adjustment, you'd think there was an association. Third topic today, little is known about the risks of major adverse cardiac events, or MACE, in individuals who receive exogenous hormones for changing genders. It's an important question because more individuals are changing genders, and because giving hormone therapy to hypogonadal or postmenopausal women has been associated with an increased risk of vascular events. So Dutch researchers set out to determine the incidence of vascular events in trans women and trans men receiving transgender hormone therapy. They reviewed the records retrospectively of a carefully selected group of 2,500 trans women who received estrogen with or without androgen suppressors, and about 1,350 trans men, and both groups were young, 30-year-olds in women and 23 in men. Circulation Journal published the study. The control group was age-adjusted incidence in the general Dutch or Norwegian populations. Over a follow-up, 9 years in trans women and 6 years in trans men, trans women had a higher adjusted incidence of strokes and VTEs, venous thrombosis, than the reference women and men, and that both trans women and trans men had a higher risk of MIs than reference women. VTE rates were most remarkable. The standardized incidence of VTE increased 5-fold in trans women getting estrogen therapy, whether the comparator was women or men. Also, the rate of MI was higher during hormone therapy of either type for both transitions when women were used as the comparator. So we should start by noting that this is an observational, non-randomized study that used medical records, so of course we should be cautious. But the authors point out that their observations are in line with previous studies, so this is not an outlier. And I would add that these seem entirely plausible relationships given the known thrombotic risks of estrogen replacement and the strong association of testosterone therapy and cardiovascular events. And I'm no expert on gender, but at minimum, this data should promote attention to risk factors in patients. And also, shouldn't this be discussed before the therapy begins as part of the shared decision to have this? Next topic is primary care physicians and health. So a team of researchers led by Dr. Sanjay Basu at Stanford studied the association between primary care physician density and population level mortality. This was an ecological study, like a before and after, enhanced by individual claims data over 2005 to 2015. Of course, it's an important topic because at the same time patients are living longer with more medical problems, far fewer medical students choose primary care. The authors found that the absolute number of PCP docs increased slightly over the decade, but due to disproportionate losses in counties with population increases, the mean density of PCPs relative to population size has decreased, with greater losses in rural counties. So they did adjusted analyses, and they found that every 10 additional PCPs per 100,000 population associated with a 51-day increase in life expectancy, whereas an increase in 10 specialist physicians per 100,000 only corresponded to a 19-day increase. And additionally, 10 additional PCPs per 100,000 population associated with reduced CV events, cancer, and respiratory mortality by a range of 0.9 to 1.4%. Now, obviously, this paper, again, observational, and the density of PCP is only one factor. So the authors used multiple adjustments, sensitivity analyses, and falsification testing, and the results, the associations did hold up. Not only that, as the editorialists point out in JAMA Internal Medicine, these findings comport well with many previous studies showing similar relationships. Now, oh boy, you could do multiple podcasts on the crisis in primary care, so I'll keep it short. First, I think the lower density of primary care physicians is probably one of many causal factors of disparate population health, like rural versus urban or poor versus wealthy counties. Second, I think a robust density of PCPs is crucial for delivering ideal health care. Sadly, in my community and others, more and more people get care from specialists. And the problem with specialists is too often we take a Cartesian view of the body as a machine. Specialists see one organ problem and they address that problem. But that model works somewhat in acutely ill patients with one medical problem in the hospital, but it's very ill-suited for outpatient care. When you have specialists just taking care of their part of the body, you get massive overuse of expensive therapies. Third, the question is how to get primary care physicians back in the game and how do we increase their density? And the editorialists point out the obvious challenges, primarily low payments. But there are other challenges too. Primary care docs are crushed with administrative burden, which is terrible because the more you care about humane and compassionate care, the more you will hate administrative burden. Of course, I don't have the answer to this problem, but if I were a healthcare czar, I would work on reducing the primary care physician's burden of administrative tasks. I would pay them more, and I would protect them legally. Final topic today. I want to point you all to a beautiful piece, a beautiful reflection on being a young interventional cardiologist. Dr. Jaya Malidi is only 2 years out in practice, and she is already noticing that the culture of interventional cardiology is a celebration of procedures. With really elegant prose, she asks her readers to consider the patients who we decide not to do procedures on. The central theme here is the tension between, yes, of course, we can do this or that procedure, but should we? And her essay reminds me of the Mark Josephson call to the EP doctors to not be proceduralists, be doctors. Take a look at this piece. I really like it. So that's it for this week in cardiology. I'm grateful that you listened. Thank you. And remember, if you like this podcast, please consider subscribing, giving us a good rating so that others can find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.